Good evening, all. Myself, Dr. Kiran Varma, working as Head of the Department Emergency, Yashoda Hospital, Malakpet. I welcome you all on behalf of Yashoda Group of Hospitals for this series of webinars connected by Emergency Department. As you all know that how important airway management is in ER. So because this is bread and butter for each and every emergency physician. Then when it comes to airway management, there are different ways. Sometimes it may be non-invasive airway management, sometimes it may be invasive airway management. See, each and every has its own advantage and disadvantage. Maybe NIV-related complications, maybe non-invasive or invasive ventilation complications might be there. So being an emergency physician, we should know when to use NIV and when not to use NIV. At the same time, when to use invasive ventilation as well. Because if you use NIV properly or on time, we can avoid invasive ventilations like intubation, ventilator support. In other way, it helps in many ways to reduce the cost burden and reduce the length of stay. It helps in many ways. Example, in case of SOB secondary to pulmonary edema or bronchial exacerbation of bronchial asthma and COPD or infections like pneumonia. So if you use NIV on time, you can avoid intubations. So by keeping all those things in the mind, we have come up with an interesting topic for today, which is we are going to discuss is non-invasive ventilation in emergency room. So to enlighten about non-invasive ventilation emergency room, we have an experienced, eminent professor, associate professor, Dr. Urjita Modi from LG Hospital, which is affiliated to Narendra Modi Medical College, Ahmedabad. I welcome you, ma'am.
Thank you. Thank you, sir. Thank you for the kind
Take the floor, ma'am. Thank you.
Yeah. So, very good evening to everyone. And I would like to thank SEMI and the Yashoda Hospital Group to give me this opportunity. Now, in this presentation, I'm going to teach the basic. I would like to stick to the basics. And we are mostly focusing on the non-invasive ventilation in emergency room. So, next slide, please. Okay, so NIV refers to the provision of ventilatory support through the patient's upper airway using a mask or similar device. So how it is different from other devices? Like in case of tracheostomy, tracheal tube or laryngeal mask tube, there is instrumentation or there is involvement of upper airway, which is not in NIV. In NIV, we are actually there is no instrumentation, there is no involvement. So NIV is distinguished from those bypassing the upper airway with a tracheal tube, laryngeal mask or tracheostomy and are therefore considered as a invasive. Next. Now there are two types of NIV, the negative pressure NIV as well as positive pressure NIV. Now the negative pressure NIV has only the historical importance. It was used in the early 20th century. Almost after 1980, we all are using the positive pressure NIV. So in our talk, we are going to focus on the positive pressure NIV. Next. So there are some historical pictures. Next, we can see one by one. That was the negative pressure NIV that were used in the past. The last one was with epidemic. Now these are some pictures. They all are having some historical importance. Next, please. Okay, so now our more focus is on non-invasive positive pressure ventilation. Next. Before we go to the further, it is important to understand the basics. Now we are going to divide the modes of NIV in CPAP, continuous positive airway pressure, pressure support ventilation, PSV, and bilevel positive airway pressure, BiPAP, which includes IPAP and EPAP. Many times it's very confusing, CPAP, IPAP, EPAP, PEEP. So we are just trying to touch each and every modes gradually. But here we are going to focus mostly on CPAP and BiPAP as we are mostly using these modes on ER. Some newer modes are proportional access ventilation, access controlled ventilation, and APRV, which may cover some later or from the next topic somewhere. Next. Okay, so this is most important to understand. What do you mean by the continuous positive airway pressure? Now the CPAP consists in the application of constant positive airway pressure throughout the respiratory cycle in spontaneously breathing patient. So each and every word is important. First, it is a constant positive airway pressure throughout this respiratory cycle. That means the same pressure during the inspiration as well as expiration and in a spontaneously breathing patients. Now, why the need of CPAP arises? Actually, what we all knows is that alveoli works on the balloon theory. If it is partially inflated, it is easy to inflate it more. In normal individual, there is no collapse alveoli. Why? Because most of the time we all have alveoli produce surfactant first, and the second thing is that whenever a patient is normally breathing, in case of expiration, there is a mid glottis closure, and because of that, there is some amount of air remain in the alveoli, which produces the pressure of the alveolar wall, which is called as a PEEP, and there is around 3 to 5 centimeters of water. Because of this mechanism, in normal person, there is no collapse of alveoli. But whenever the patient having intubation or patient having disease condition, this pressure may be lost. So in this condition, we need this CPAP. Next. Whenever the alveoli collapse, the local ventilation falls while the local perfusion may be sustained. So it will lead to the VQ mismatch and causing the hypoxemia. In case of CPAP or continuous positive airway pressure, it will increase the FRC, reduce the VQ mismatch, and improve the oxygenation. So this is the concept of CPAP. Again, whenever you are going to use the CPAP, you need a ventilator, you need a machine which generate the flow. There's a continuous generation of the flow is needed, and this flow must be more than the peak inspiratory flow rate, and it has to be the same at all the times. Otherwise, there's a fluctuation of the pressure. So this circuit will give us some idea. The flow generator is here, tight fitting mask, patient face, and there's a valve which to regulate the pressure. Next slide, please. So this is like you can see, it is unassisted breathing. And the next one, this is the assisted breathing with the help of CPAP, the intra-alveolar pressure. So now I think everyone has a concept of CPAP. So CPAP is a continuous pressure throughout the same respiratory cycle. It is mostly important to prevent the alveolar collapse, and it is useful to prevent the VQ mismatch. We are going to see the effect in detail in next slides. So the effects of CPAP, it recruits the alveoli and improve the shunting. There is minimum VQ mismatch with the help of CPAP. So by this way, it reduces the work of breathing, elevate the respiratory distress, unload the respiratory muscles. It improves the respiratory muscle function, improve the gas exchange, and useful in hypoxemia and some point of view hypercapnia also. Apart from that, on cardiovascular, it is going to decrease the left ventricular transmural pressure, and by this way, it is going to decrease the afterload as well as preload, which is again beneficial for the patient. Next, please. Okay, now the concept of BiPAP. Now again, sometimes the NIV and the BiPAP, they both are used as a synonymously. Sometimes in layman we use the NIV, it is almost like a BiPAP. But actually the NIV having subtypes of BiPAP and CPAP. So NIV in rough term we can mention as a some form of pressure support. But why we need the pressure support? Now normally it happens, any type of disease, any type of lungs, any type of chest wall deformity, or any type of muscle deformities, patients may need some pressure support. This is some type of positive pressure support. Now, how it works? Now, the main concern is that, as we know, whenever the inspiration starts, there is a contraction of muscles. Because of this, there is a thoracic cavity volume is going to increase. And at the same time, the pressure inside the pleura or the interpleural pressure is going to drop than the atmospheric pressure. So whenever we need to use BiPAP, we need such machine which triggers, which using either this thoracic increase volume or decrease the pressure can act as an inspiratory trigger. So it is sensed by the machine, and depend on that, machine provides inspiratory pressure or provide the flow during the expiration. Next slides, it is going, we are going to discuss detail in the next slides. Okay. So whenever we are going to use the NIV, or more commonly we told as a BiPAP, the basic requirements are the pressure and the flow generator ventilator, ventilator tubing, and the interface to connect the system to the patients. All machines should be back please. All machines should be capable of providing the high gas flow to maintain a preset airway pressure at the end of the expiration, which is called as a EPAP or maybe PEEP. And apart from that, all the machine should be delivering the inspiratory positive pressure. This is called IPAP. So now the concept is very clear. Whenever we need to give BiPAP. It has two component, IPAP as well as EPAP. And the machine has a trigger. The trigger point would be either increase the thoracic cavity volume or decreases the interpleural pressure. This triggers will sense the patient has starting of inspiration. So at the end of inspiration, at the start of inspiration, the machine will give IPAP, and with the help of pressure support. And then at the end of expiration, whenever the expiration will be there, machine will provide a certain flow. So the sum amount of the pressure generated at the alveoli, which is almost equivalent to PEEP, and that is called as a EPAP. Next slide. So I hope now everyone has a clear concept about CPAP and BiPAP. So in CPAP, we have the continuous throughout the cycle, the same pressure. In case of the BiPAP, we have different IPAP as well as different EPAP. Next. So now the BiPAP. Effects of BiPAP, it again increases the FRC, it preventing the end expiratory collapse and improves the lung compliance. It improves the respiratory muscle function. Apart from that, it is very useful to the delivery of the bronchodilator to the distal bronchial tree. It improves the gas exchange by alveolar recruitment and corrects the hypoxemia. More or less, the effect of CPAP and BiPAP are most of the time, it is quite similar. But again, next slide, please. If your patient having type 1 failure, hypoxia failure, so for ED point of view, we mostly encounter the cardiogenic pulmonary edema patient or CHF patient. The CPAP, non-invasive CPAP would be more beneficial and it has to be preferred. In case of type 2 failure, hypercapnia mostly, we have to prefer the BiPAP, like patient with a COPD with acute exacerbation. So we have to prefer a BiPAP. Most of the time, there are two absolute indications of non-invasive ventilations are cardiogenic pulmonary edema, in which we have to prefer CPAP. Another is the COPD with acute exacerbation. It is a hypercapnic failure, in which we have to prefer the BiPAP. Next, please. Okay, now how to set the ventilators? So for the bilevel or BiPAP, we can set like this. We have to set the mode spontaneous set. Now we can set the EPAP around 4 to 5. As we all know, EPAP is almost equivalent to PEEP. So we can set EPAP 4 to 5 centimeter of water. The IPAP should be 12 to 15 centimeter of water. And we can increase as per patient tolerance up to 20 centimeter of water triggers with maximum sensitivity. Backup rate must be there because most of the BiPAP now have with the backup rates. And backup IE ratio approximately 1:3. Next, please. Again, to just summarize the whole thing, CPAP, as we already discussed, there is a continuous positive airway pressure throughout both inspiration, during expiration, or throughout the cycle, and it in a spontaneous breathing patients. So the setting would be from the 5 to 12 centimeter of water. It is mostly indicated in type 1 or hypoxemic failure like cardiogenic pulmonary edema or CHF, where in case of BiPAP, we have two component, IPAP as well as EPAP. IPAP, what we are going to set is roughly around 10 to 20 centimeter of water, and EPAP would be around 5 to 10 or 5 to 12 centimeter of water. It is more useful for the hypercapnic or type 2 failure. Next, I hope now we have almost covered the basic concept. What are the subtypes of NIV? What is the basic pathology and physiology about CPAP as well as BiPAP, and when we should use it. But now why we are discussing, why the interest in NIV so much? So as we have already discussed, the important thing is that to avoid the complication of invasive ventilation. Most of the time, intubation and mechanical ventilation has complications like aspiration, trauma, arrhythmia, hypotension, barotrauma. Apart from them, when the patient remains intubated for prolonged time, there is loss of airway defense mechanism, chronic bacterial colonization, and maybe develop VAP after 24 to 48 hours. Next. Apart from that, complications even after post-extubation, like hoarseness of voice, sore throat, coughing, sputum production, upper airway obstruction, many times hemoptysis, many times extensive trauma. Next. And apart from that patient's point of view, patient having more discomfort with invasive intubation, difficult to communicate, difficulty in eating, like that. Now the prerequisite. Here I would like to address each and every student that it is very important when you select for the BiPAP, your patient must be fully conscious. There is no role of non-invasive ventilation if your patient is drowsy, if your patient with altered sensorium, if your patient is comatose. Never try such things. If a patient having GCS less than 8, better to go for intubation and then, if needed, invasive ventilation. But attempt only BiPAP when your patient is fully conscious, communicating and able to cooperate. Patient can control the airway and secretions. Adequate cough reflex must be there. Patient is able to coordinate breathing with the ventilator or with the BiPAP machine. Hemodynamic stability is again an important point, because many times there is always a dicey situation when the patient having hypotension and patient having failure also. So it's always a dicey situation, but it's always recommended that your patient must be hemodynamically stable. Even though the book suggests that your patient with CHF, if it is hemodynamically stable, then and then they try BiPAP. Otherwise, you have to go for the other modes of ventilation. pH should be more than 7.1, PaCO2 less than 92 per milliliter of mercury, and normal functioning of GI tract. Next, please. Now we just discuss with the indication. So in ED, the most important indications what we encounter is acute respiratory failure. In acute respiratory failure, mostly we all experience the acute exacerbation of COPD very frequently. This is the most important indication. Now, till apart discussion, now everyone is having clear thought that if it is a COPD type 2 failure, the BiPAP would work better. So the BiPAP should be considered in patient with acute exacerbation of COPD, in whom acidosis persists despite of maximum medical treatment. We are going to also further discussing the indications and the role of BiPAP in COPD. But mind well, when your patient with COPD, if the patient's pH is normal with moderate or more elevated CO2, you have to think of like other treatment. But whenever the pH starting falling in the patient having respiratory acidosis, you have to immediately apply the BiPAP to the patient. Here the success rate is very high, 80 to 85%. It increases the pH, decreases the PaCO2, and decreases the severity of breathlessness in almost the first 4 hours of treatment. And by this way, decrease the length of stay, decrease the mortality, and decrease the intubation rate. Next. Apart from that, post-extubation, many times we use as a, in COPD patient, many times weaning adjuvant, we can use the BiPAP. On grade C evidence, we have thoracic wall deformities, neuromuscular disease, status asthmatics, and acute respiratory failure in obesity. Next, please. The second one is hypoxemic acute respiratory failure. Again, here the role of CPAP is more important than the BiPAP. We have this type of patients like CHF or cardiogenic pulmonary edema. The role of CPAP is over here. So the CPAP has been shown to be effective in patients with cardiogenic pulmonary edema who remain hypoxic despite the maximum medical treatment. NIV should be reserved when the CPAP is unsuccessful. Again, with the help of CPAP, we can improve the mortality. We can decrease the rate of need for intubation. So mind well, whenever the type 1 failure, you have to always try CPAP first. If it is not possible, then BiPAP, or if not, then some standard care. Next, please. Another important indication it is community acquired pneumonia. We mostly encounter, it is again a mostly type 1 failure in initial stage. So CPAP improves the oxygenation in patient with diffuse pneumonia. It prevents the VQ mismatch, prevent the shunting, and it is used when the patient remain hypoxic despite of maximum medical treatment. Next. We also have some grade C and D evidence like post-traumatic respiratory failure and in ARDS. Again, in ARDS, we all are commonly using, sometimes we are using the newer modes like APRV, APRV biophysics, we can use, but that's all having grade D evidence in case of using of NIV in ARDS patients. Next. Now we talk about the chronic respiratory failure. This is very important to understand. Mostly chronic respiratory failure are of two types. One is restrictive disease, one is some type of obstructive or COPD. Next, please. So here it is important when your patient is a restrictive thoracic disorder, what you have to look for. The important thing is ABGA. If any case your ABGA, PaCO2 shows more than 45 minutes of mercury and the nocturnal SpO2 less than 88 for 5 consecutive minutes. Many times we just see the patients and like we directly jump off of BiPAP we are not thinking about the spasm, not thinking about the desaturation. So it is always important to follow the protocols or guideline. We have to check for the MIP and we have to check for the FEC, and then take the call for use of BiPAP. Now for COPD and hypoventilation syndrome, like OSA and COPD, which we commonly encounter. Here I again, whenever I see the patient of COPD, I usually ask my resident doctors to just take the history that in last 12 months, how much of episode of COPD patient has. So why? Why I'm asking this? Because the criteria is like that. When you're going to apply the BiPAP, first, your PaCO2 more than 55. Second, your PaCO2 50 to 54 with SpO2 less than 88 for the 5 consecutive minutes. Third, your PaCO2 is 50 to 54 with recurrent hospitalization for the same hypercapnic respiratory failure for more than 2 months in the last 12, for more than 2 times in last 12 months. So these 3 points are very important. Even though your patient's PaCO2 is 50 to 54, but patient having history of the same type of respiratory failure and 2 hospital admission in the last 12 months, we have to think about the NIV. So whenever you encounter the patients with COPD or mostly OSA, just ask the how much episode of such type of failure in the past, in the last 12 months, he or she has observed, and then decide, depend on 3 criteria you have to set and ask for the NIV. Next, please. So apart from that, the immunocompromised patient has benefit. Sometimes in ICU do not intubate patients, and in sometimes ICU like to facilitate some procedures like bronchoscopy or GI scopy. So just next slide, please. Just to summarize, the strong evidence COPD must acute cardiogenic pulmonary edema, immunocompromised, and to facilitate weaning. Intermediate evidence include asthma, extubation failure in COPD, post-operative. Now, in what happened in COPD, many times we keep the patient on TPs, and the patient develop reflect bronchial spasm, and then again become tachypneic. So the cycle is going on. So what we do, we usually keep the patient on low pressure CPAP. We extubate the patient on COPD after checking for SBT and ABGA. And if everything is well, we extubate the patient and keep on BiPAP for the first 24 hours, which is sometimes give good beneficial effect in COPD. And it is clinically, many times it is proven that instead of giving TP's trial, better to extubate the COPD patient on low pressure CPAP to avoid that bronchospasm and all other complications. Next, please. And the weak evidence or optional include ARDS, cystic fibrosis, neuromuscular disease, chest wall deformity, sometimes OSA, but not recommended when your patient having post-op upper GI or upper airway surgery. At least I have asked to so many surgeons about this. So almost everyone is same opinion for at least 48 hours, 24 to 48 hours. If any incision, which is like above the umbilicus, please don't try BiPAP to such patients. And the fixed or maybe dynamic upper airway obstruction, we should not try BiPAP. Next. Now, what are the benefits? Again, already we have discussed. It avoids the complication of invasive ventilator. There is no need of sedation. Very, very, very rarely we have to give minimum sedation for that apprehension and claustrophobia. Otherwise, we can avoid the heavy sedations. Maintain ability to communicate. Allow the intermittent eating or drinking. We can keep the patient for nasal prong for some time, but we used to do in COVID, and allow the patient to eat and communicate with us. Avoid the complications related to invasive ventilators like WEP, etc. Next. Oh, so we are in the middle of the lecture, middle of our webinar, and it is an online lecture, and hope you know in such state. So like to quickly, we discuss on the contraindications, facial trauma or burns, or what I can say, whatever the structures on which the mask is going to be there or mask is going to stay, that structure should be intact. So facial trauma or burns, recent facial upper airway or upper GI surgery, fixed obstruction, inability to protect the airway, life-threatening hypoxemia, hemodynamic instability, severe comorbidity, impaired consciousness, as I already discussed, don't attempt to the patient with impaired consciousness, confusion, agitations, severe vomiting, maybe chances of aspiration, Bowel obstruction, again chance of regurgitation and aspiration. Copious respiratory secretions which interfere with the gas exchange. Focal consolidation on chest X-ray, and undrained pneumothorax. The last one is very important. Many times we see the COX patient, COPD patient with severe distress, and we may find the pneumo on the X-ray. So whenever you can find any pleural pathology with tachypnea, it is better to resolve that pathology first, and then you have to attempt any type of ventilation. So the undrained pneumothorax, try to put the ICD first, and then plan for NIV or non-invasive ventilation. Next, please. So now we are going to discuss about the interfaces. Interfaces are simply they are the devices that connect the ventilator tubing to the face and allowing the pressurized gas to enter into the upper airway. Whatever the gas we are delivering to the patient under pressure, and that with the help of this interface, it is delivered to the patient's upper airway. Next, please. So we have different type of devices. First is a nasal device. Here, as you can see, it is a cone-shaped device. We're having soft cuff. It is in multiple shape and size available. It is better tolerated by the patient with claustrophobia, because many times patient with dual mask, oro and nasal, may complain of claustrophobia. It is again useful with the patient having OSA and patient has to take long-standing BiPAP, or every night patient has to take BiPAP. But it exerts the pressure over the bridge of the nose. The disadvantage is that when the patient, most of the time we have mouth breather patient, so whatever the volume we are delivering, whatever the gas we are delivering, it may be lost by the mouth breathing, and apart from that, it will produce the more resistance sometime. Next, please. There are some example of nasal mask. Next. The nasal mask is like, it has the forehead support. It has a thin, like as you can see, it has the forehead support, thin, flexible and bridge material, which bridge the support and the mask. There is the cushioning over the dual flap cushioning with the mask, and the 360-degree standard elbow. So because of that, whenever the patient moves, there is no dragging of the circuit or like that. So it is always a 360-degree swivel standard elbow. Next, please. The second one is oronasal or full face mask, which we are commonly using. So mostly whenever your patient is suffering from any acute setting, like as I already discussed, the patient having OSA and every night patient has to take BiPAP, so nasal mask is quite comfortable and preferred for the patient. But if your patient is already presented with a type 1 failure, severe type 2 failure, COPD, acute exacerbation, so in the acute setting, it is better you just give oronasal or full face mask. So it is preferred in acute settings. For patient with copious air leaking through the mouth, but the patient is like a mouth breather, and whatever you are going to deliver through the nose, it will come out from the mouth. It is not accepted. So for such patients, and for the edentulous, because in edentulous there is always a hollow cheek, there is always air leak must be there from the mouth. The limitations: it interfere with the speech, eating, and expectoration. It increases the risk of aspiration and rebreathing. Many times, if you are not going to properly set, it may happen the patient may rebreathe whatever the patient is going to expire, and increase the likelihood of claustrophobic reaction. Many patients develop claustrophobia with such type of mask. Next, please. This is a classical mask which we all are using very commonly. Next, please. It's also called as a full face mask or oronasal mask. It's same like a nasal, last slide, please. The same like as a nasal mask, it has a double form cushion, adjustable forehead support, the ball and socket clip, entrainment valve, and apart from that, they had the pop-off of pressure pick-off support. Many times it may happen that if a new resident may not aware, it may set more pressure or more flow, so patient may have discomfort. Many times, sometimes the pressure under the mask is so much of increase. So in this condition, this pressure pick-off of pop-off valve just pop off and release the extra pressure. Next, please. This again important is nasal pillow, nasal cushions, but they all have role for the chronically patients and suitable for the patient with claustrophobia, with the skin sensitivity reactions, and when there is a need for visibility. Next one. The mouthpieces are also available. It provides the NIPPV to the patient with chronic failure. They all are devices apart from oronasal mask or full face mask. All devices are mostly for the chronic patients. They are simple, inexpensive, but the problem with the mouthpiece, The same, when we are going to deliver the volume, there may be the leakage or loss of volume from the nose. So nasal air leakage we should decrease. How? We can manage by increasing the tidal volume. Many times in BiPAP, there is a problem. There is lots of air leak, which we may encounter with the help of increasing some amount of volume. First thing, or second thing, we can occlude the nostril with the cotton like plates or nose clips. Next. And this is important is helmet mask. Whenever the COVID epidemic were started, everyone was in fear of that droplet spread. So at that time, the guideline was suggested of using the helmet mask. Now in the helmet mask, the important thing is that there were like in other masks, there is extensive spread of droplets, but it is very less or minimum with such helmet type of mask. So the complications like necrosis, gastric distension, irritation, they are almost minimum. Patient is very comfortable with such type of mask, but they are somewhat costly. They are not easily available. And apart from that, there is no any like advantages over the length of stay in ICU, intubation or mortality. They are almost similar with the other type of mask. Next, please. Okay, so the other important function is humidifications. Now, as we all know, humidification is very important. Mostly in case of intubation or invasive ventilation, we are bypassing the upper airway, which is not in NIV. So humidification is not a great problem, but here what happened? Whatever the gas are delivering, they are with the high flow, they are with the pressures. So that gases are dry, which lead to the irritation, which lead to drying of nasal mucosa. So we have to apply the humidifier. Whatever the conventional HME or heat moisture exchanger we are applying on ventilator, it decreases the effectiveness of BiPAP here, and sometimes that filter get blocked. So again, it will lead to the problem. So here I suggest we have to use the pass-over humidifiers. Next, so in picture we can show. Next slide, please. So here you can see there is a pass-over humidifier. So when you are using the BiPAP or NIV or the CPAP, you have to use the only pass-over humidifiers. Next, please. Now, just to summarize, what are the steps in the setting up of NIV? First, decide about the management plan. Even when I take round, I ask my resident, okay, before you plan for extubation, just keep in mind if the intubation will occur, what you should do. So the same thing, whenever you decide to put the patient on NIV, you have to keep in mind if NIV will fail, what should be our treatment plan or the protocol or the modalities. Decide where the trial should be given, whatever the place, ER, ICU, casualty. Consider informing all the staffs, medics and paramedic staffs. Now, explain the NIV to the patient is again very important. You have to explain to the patients about the NIV. Select a mask which is properly fitting. Many times we observe patient having small mask or sometimes big mask. So small mask, big mask are not effective. Patient may have extensive leak or sometimes patient having grip breathing, not properly ventilated, which we can see easily on the scalas. If the patient having, we are using with the ventilator, we can easily see the scalas, flow and volume scalas, and we can make out that tidal volume is not going to deliver adequately apart from that patient having leak. When you set the ventilator, hold the mask for some time. Either you can ask the patient to hold the mask on the face, or you can hold the mask and then you can like apply with the headgears. Apart from them, set up the ventilators, attach the pulse oximeter. These both things are very important. Pulse oximeter is most important monitoring you have to do. Commence the NIV holding the mask in place for the first few minutes. Secure the mask in place with the straps or headgear and reassess after a few minutes. Sometimes it is easy to intubate the patient and monitor, then difficult to manage on BiPAP. There should be no death on BiPAP. Whenever you keep the patient on BiPAP, it's your duty to assess and reassess the patient at regular interval. Next, please. Adjust the settings if necessary. Now, many times we have some old BiPAP machines in which we don't have that direct oxygen port. So sometimes we have to add the extra oxygen with the help of port if SpO2 is less than 85%. Instruct the patients how to remove the mask and call for help whenever he or she needs. Clinical assessment and ABGA must be there. Now here I have some clinical experience I just want to share. What are the literature says? Once you put the patient on BiPAP, at least within 1 to 2 hours, patient should have some clinical relief. And within 4 to 6 hours, patients' ventilatory settings suggestive of like ABGM must be improving in within 4 to 6 hours. So here, at least you have to take first ABGA at 1 to 2 hours, and the second ABGA should be taken at almost 4 to 6 hours. Next, please. Monitoring, clinical monitoring is very important, like chest wall movement. We have to check the coordination of the machine and the patient, accessory muscles recruitment. Apart from that, heart rate, respiratory rate, patient is comfortable or not, and patient's mental status. Anytime you feel your patient become drowsy, your patient GCS is dropping on BiPAP, you have to think of invasive modality. Please don't continue the patient who is not in an adequate or proper conscious state. Next. The oxygen saturation is already discussed. It is very important. At least for the 24 hours after commencing NIV, supplementary oxygen administered to maintain the saturation between 85 to 90%. At least 85 to 90% must be there. It is desirable if you keep it more than 94, but 85 to 90% is must. The ABJ is already discussed. Now again, the guideline will say at least draw an ABJ at 1 to 2 hours, send that ABJ. If this ABJ is good, well enough, you just continue with the same settings, continue with the BiPAP. On first 2 hours ABJ, it is not showing good result. You may adjust the setting. Still, you can continue on the BiPAP and take the again ABJ at 4 to 6 hours. Even if your 4 to 6 hour ABJ is also not well, not improving or showing deterioration, it is better to go with elective intubation or elective going for invasive ventilation. This is very important to understand for each and every resident where to take the ABJ. The first sample should be taken at 1 to 2 hours and the another would be at 4 to 6 hours. If 1 to 2 hours is adequate, well, good, maintain the same setting. If it is not good, change the settings, correct everything, again take at 4 to 6 hours, again the 4 to 6 hours ABJ is deteriorating, better to go for invasive ventilations. So now quickly to the adverse effects and complications. Mask related, nasal pain, and important is nasal breach, erythema, ulceration, and I must say necrosis. Like when we keep the patient on BiPAP for prolonged time, we can see the nasal breach, ulceration, eventually necrosis. We can use a tegaderm. Simple, the tegaderm rules are available. We can cut and we can put the tegaderm over the bridge of nose. So it will be very helpful to prevent such complications. Now the airflow or pressure related complications, like sometimes the patient having persistent very high flow may lead to irritation, conjunctival irritation, sinus pain, nasal or oral dryness, nasal congestion, and gastric insufflation. Gastric insufflation is very important. Most of the time, we prefer to insert the RT. So whenever whatever the air goes inside the stomach, we can easily and keep it open so we can easily remove that air. So gastric insufflation should be taken care of. Next. When we consider the failure of NIV, the most important causes are mask intolerance. Many times patient is not going to tolerate the mask. We start the ventilation, we start the adequate setting, even though there is a failure to improve the ventilation. Claustrophobia, excessive air pressure, patient has feeling of excessive air pressure, and the patient and ventilator asynchrony. Many times patients are quite sick, patient having some comorbid disease along with that. And even though we keep on trying, but there is continuous asynchrony between the patient and the ventilator. Next. So in this condition, we need to discontinue the NIV. So what are the criteria where we should plan from NIV to the other modalities or invasive ventilation? First, inability to tolerate the mask because of extensive discomfort or pain. Inability to improve the gas exchange, same. Or dyspnea. No, there is no improvement in dyspnea, no improvement in gas exchange. So we have to think of need for intubation to manage secretion or protect the airway. Sometimes patient having extensive secretions, need to protect the airway. So no role of BiPAP or non-invasive ventilation. Hemodynamic instability. Your patient was initially stable, you put on BiPAP, but now eventually they develop instability, developing the ischemia or arrhythmia, cannot continue the NIV, and failure to improve the mental status. Sometimes in CO2 narcosis, we usually consider the patient's alert, but eventually the patient develops full-fledged narcosis and become altered mental status. In COPD, this is very commonly we observe. So we have to discontinue the NIV. Next, please. So this is almost all the basic concepts they related to the NIV. So my take-home message would be you have to carefully choose the patients. You have to carefully choose the mode. If you have a type 1 failure, hypoxemic failure, better to go with non-invasive CPAP. If you have type 2 or hypercapnic, better to go with BiPAP. Just give time to the patient. Explanation to the patient is very important. Assessment, reassessment, close monitoring is very important, and have to take a call when to go for the NIV. Next slide, please. Next slide. I guess no one is in such mood, and I really would like to appreciate and thank all the listeners for this passionate hearing. Thank you so much. Thank you. Next, please. Thank you. Thank you, sir. Over to you, sir.
Yeah. Thank you, Dr. Urjita Modi. So for your great presentation, undoubtedly it is a great presentation. In fact, you have touched all the aspects of NIV ventilation.
Thank you, sir.
Includes like prerequisites for NIV, indications, contraindications, then what are the interfaces available, then setting initial setups of NIV, then adverse effects. So you have touched all the areas of NIV. Thank you so much, ma'am, for your
Thank you, sir. Thank you so much, sir.
So there are few questions, ma'am. Can we take up those questions? Yeah, first question, ma'am. So role of NIV in hypotension patient.
Yeah. Again, like hypotension is what I call is a like double-edged sword. Many times what I feel in our clinical experience, the patient with failure and with a cardiogenic shock. So what happens sometimes, okay, we keep the patient on BiPAP, so it's a relative contraindication, as patient is unstable hemodynamically, and sometimes we prefer to intubate. Now in intubation, again, we have to give some amount of sedatives, maybe called propofol or midazolam, whatever, to facilitate intubation. That again may aggravate the arrhythmia and hypotension. So my suggestion would be is that if in case of hypotension, better to start with inotropic agent or whatever the etiology, if it is correctable, just try to correct it. If it is possible to continue, keep continuing BiPAP. And if you find now it is like BP is reaching about 80, 90 systolic, it is not possible, it is highly in unstable category, you can use etomidate or such type of drug which do not much affecting your cardiovascular system. You can safely intubate and better to keep the patient on invasive ventilation.
Thank you, ma'am. One more question. So role of NIV in blunt chest trauma.
Sir, in blunt chest trauma, like main condition is what? In blunt chest trauma, most of the time patient having multiple deep fractures. And like there is no any specific treatment. Like we have to wait till all the deep fractures are going to heal. Now what happened? Most of the time in chest trauma, the important problem is pain and tachypnea. So whenever the patient having pain, tachypnea, there is always a rib friction, and because of this friction, whatever the contusion is aggravating may have more drain. So my suggestion would be that okay, if the patient having chest trauma, we can definitely use BiPAP. If your patient is very cooperative, you can use. The another thing is that you give such support to the patients, and because of that, the tachypnea will be controlled. But apart from that, you may use some regional anesthesia or analgesia, what I call analgesia, or we can use Dexam. We used to use Dexam in such type of patient is the ideal agent. So we just control the pain and we can continue with the BiPAP. But in such type of patient, it is important we can have regular monitoring of X-ray. So and regular check for the drain output. But still we can continue if the patient is stable. We can have some good amount of regional analgesia or IV analgesia, and we can keep the patient on such type of mostly CPAP would be preferred. We can keep on non-invasive CPAP.
Yeah, exactly. Mainstay of treatment is pain management. Then we can use NIV.
Yeah.
Then one more question, ma'am. So can we use NIV for pre-oxygenation?
Yeah, I I don't know. Actually, now there's a new concept. When we were resident, we used to use that ambu bag. But now what I observe, even our doctors do the same thing. They keep on 100% O2 and then they keep. I can't comment anything. I have not seen any difference. We used to do with ambu bag. Still, we used to do with ambu bag, and they are doing with this. So it is not anywhere. It is not indicated that you can use BiPAP as a part of pre-oxygenation. Yeah, people have started using this. but still, like, if you can comfortable, use it, but it is not a anywhere it is in recommendation or any evidence. Still, our that ambu bag method is better. 3-minute oxygenation. That's what I suggest.
Yeah, we also face the same thing, ma'am.
Yeah, because many times what
Whether-
they do, they keep they prepare for the intubation. At the same time, they keep on BiPAP for 100% FiO2. And again, it may happen when you plan for the intubation and pre-oxygenation, your patient may be with altered mental status most of the time when you plan for the intubation. So it's better to give with ambu bag and 3-minute oxygenation. They what we used to follow instead of putting such patient on BiPAP with 100% FiO2. So there is no any recommendation in any book that
Yes,
you
yes.
have to do such
So we
things.
will follow the same thing. When patient has spontaneous breath, we go with the NRBM.
Yeah,
If patient is not having spontaneous breath, we can go with the bag mask ventilation.
definitely, sir.
But
That's what
we
we used
rarely
to follow
use
since.
the NIV
Yeah,
for pre-oxygenation. But
yeah.
there are many studies on that, ma'am. Certain
Okay.
areas they are using NIV for pre-oxygenation as
Okay.
well.
Okay, sure.
Okay. Then one more question, last question.
Yeah,
So how
sure.
to diagnose bronchospasm on clinically by auscultation?
Um, okay. So like there are two type of spasm as we all are aware. One is the laryngeal spasm and one is the bronchospasm. Now in laryngeal spasm, what happened? There is reflexly closure of vocal cord. So there is no air entry. It is almost a silent chest many times. And many times in case of laryngeal spasm, you may have some aggravating factor. What I on my clinical experience, what I would like to address, the bronchospasm is not actually word. The actual word is a bronchular spasm. Okay, so whatever the spasm at the distal bronchioles level, it is very difficult to treat sometimes. So many times we can make the differential diagnosis depending on patient's clinical condition, patient's history. If the patient with bronchular spasm, definitely they are going to improve by bronchodilator or steroids. So, like, it is almost easy to diagnose, easy to differentiate between both of them. And the bronchospasm, they have discrete air entry. They are almost 90% bronchospasm after bronchodilator, IV, or through RT, or sometime with MPS. They are going to give a response, which is not possible with this laryngeal spasm. So, bronchospasm have a discrete air entry. Sometimes you have like silent type of chest and having some history of COPD or some restrictive or obstructive lung diseases. So we can make rule out on them. And they're mostly give a response to humidifiers and nebulizers.
Yes. So one more question, ma'am. We got this. So we have mostly observed patients being put on BiPAP in CHF patients, still responding well to it. Any harm in using BiPAP in CHF patients?
No, I have not like as I told now, there are two most important absolute indications are hemodynamic stable CHF or cardiopulmonary edema and COPD exacerbation. So in like as we know the pulmonary edema, what we need to do, like we need the fluid redistribution, which is with the help of BiPAP pretty we can achieve. Apart from that, we use usually fentanyl or some type of derivatives for that sympathetic outflow management also. So there is no harm in putting the patient with CHF, but you have to always take care of hypotension. You have to assess the patient, and whenever the instability develop, then as we have discussed, we have to think about invasive judicially with risk and versus benefit ratio.
Yes, ma'am, we are getting many questions. Then this is the last one.
Yeah,
So
sure.
we will get any more questions. Ma'am, please elaborate on how to set up a BiPAP machine in terms of setting like PEEP and PS values.
So actually, like our topic, what we are discussing, na, there are other modes are also APRV, PAC, and there are hi-fi modes for BiPAP. As already discussed, okay, if your patient having in most of the ventilator nowadays, most of the ventilator, we all are using whatever the Schiller, Vela, whatever. They have CPAP mode. Okay, so they have non-invasive CPAP is also there. With the type 1 failure, you can start. In case of CPAP, just try to keep the start from the 12 and then gradually increase. The PEEP should be around 5 or 6 and the FiO2 depend on your ABGA. What I suggest to my resident, your FiO2 to PO2 ratio would be like 4 to 5 times. So you have to set the FiO2 like that, first thing. The other thing is that when you are going to keep such pressure, every patient's lungs are dynamic. Like whatever the patient suits to me, it's not to the other patient. So the range is there. You can start with 12 and you can increase gradually up to the 20. Even though you feel your patients and each monitor is showing the patient's data. So every time I ask for the patient to ask for the resident to check for the ratio, tidal volume by RR. So even though I reach maximum on CPAP and my ratio is less than 10, for what my rate is around 300 and RR is, sorry, my tidal volume is around 300 and RR is around 35. So the ratio is less than 10. So in any condition, tidal volume is low, rate is more, and you exceed the maximum pressure on non-invasive CPAP, better to go for invasive or some other modalities. And in case of BiPAP, again, we have NIV mode in most of the ventilator setting. You can set the EPAP as well as IPAP. Many times it is confusing. So just assume that your EPAP is equal to your PEEP. And roughly your PSV is equal to combination of both, because whatever the PEEP you are going to apply, that is going to add on the next cycle. So you can either IPAP or EPAP you can set, or you can set PEEP and the pressure support in NIV also. And again, they have trigger and they have FiO2, and you can adjust with the IGME ratio.
Yeah, thank you, ma'am. Thank you so much. Before I conclude this session, so I'd like to thank Dr. Srinath for creating such a great platform to spread our knowledge. So in fact, it is useful for the many youngsters.
Sure, sir. Sir, Srinath sir, I would like to thank from the bottom of my heart to giving me such opportunity and to interact with the young EMD doctors. Thank you so much. Thank you so much to everyone. I hope I could percolate some amount of knowledge to the freshers, to the new young EMD doctors.
Yeah, true, ma'am. Then I would like to thank Yashoda Hospital Management for organizing all these things.
Kiran, one Dr. Vijay has raised his hand.
Vijay?
Dr. Vijay.
Yeah.
Dr. Vijay, you are online. You had raised your hand.
There's no question, sir. He just raised the hand.
Okay, Vijay. Okay.
Yeah, I thank Semi and Semi for supporting in all the ways, then Amba and LG Hospitals. I thank you all the viewers and participants for all these things. Thank you, one and all.
Thank you so much, sir. Thank you. Can we leave, sir? Yeah.
Yeah,
okay, see you in the next session. Thank you, sir.
Dr.
Thank you, Yashoda Hospital and the whole the management team for putting effort, sir. Thank you so much.
Thank you, sir.